Hey, good morning. I'm Ed Ullmann from Wellness RX Pharmacy. Today, we move forward looking at ideas to address new and old challenges with the American healthcare system. And I go, let's start with really the most immediate challenge that I can see, and that's access to care. You know, COVID has hit the system hard. And we just watched the highest number of early retirements of healthcare professionals, especially our senior doctors and senior nurses. And then you add that to the loss of clinicians from the mandated vaccinations. And when we look at it right now, we have about, on a net basis, about a 3% clinical loss of health professionals in America. And then when we add that to before COVID, where we had an estimated shortage of 40,000 primary care doctors, I think we have to look at access to care right now is critical. And I think we especially have to look at that the shortages are going to be more acute in the areas where we have the most medically underserved communities, and in the South, which has been growing at a record pace over the last decade. So let's look at first what works, what has worked for us, and let's build on these things that we know have worked in the past. The first one I'd like to talk about is federally qualified community health centers. Now, this is a novel thing that's been around for about 40 years to help provide increased access to services for the poor. They concentrate in medically underserved communities in America. What I like about them is that they are able to attract high-quality doctors because the federal government subsidizes or retires most of the student debt for doctors who are willing to make a multi-year commitment. So overall, the quality of care is held up quite nice at these centers. And what I also like is that these centers cannot refuse care to anyone, and they must offer a sliding fee schedule for anyone that needs some help. So I go and say, let's concentrate on things that have worked in the past for access. Federally qualified community health centers are, to me, number one up there. Let's do more of them. I then also say we have to increase the number of internships and training positions for new physicians, and especially for the mid-level professionals, like our nurse practitioners and our physician assistants. They have shown to be low-cost providers. They're as efficient as doctors, and they're well respected and received by the public. So let's increase the amount of training opportunities for these practitioners. And what we can't do is just rely on Medicare to provide funds in order to increase the positions, especially the internship positions, because it's been frozen. The Medicare dollars for increasing positions has been frozen for 10 years. So let's be a little more creative on this. And what I say is that right now the HMOs, or the managed care organizations in our country, have done very well through COVID. They have not had to pay out a lot of claims because people didn't go to the doctor as often, and they were able to collect the premium. What I would say is let us add a special medical access tax of about 1/4%, and let's add it and ask and request the HMOs and the jurisdictions of each state to help provide the funds that we need to increase the internships and the training opportunities for the future, especially for all the young Americans that want to be of service to others by providing care, healthcare services to the people who need it. I also say we challenge our young adults. They're motivated coming out of COVID to want to make a difference. Let's challenge them to go in to become mental health professionals. Let's go and tell them where else we need, the specialties we need help. Challenge them. In return, pick up their scholarships for going through school, and in return, ask for them to give us a 5-year commitment of their time to public service. It would be a win-win. We can do it. We should do it. Next, I say we give our pharmacists the incentive to expand their clinical services and to become public health leaders for their communities. You know, we pharmacists stepped up during COVID. We did 30% of all vaccinations in the country, but we can do much more. And now's the time to have and give pharmacists what we call provider status. It's to be done at the state level. It's done in other states, which will allow them to get reimbursed for the clinical services, and they'll be treated like a mid-level professional. The time is now to do this. And, you know, in the future, let's reimburse pharmacists to come in on the same side with the patients and not to fill prescriptions if it's not needed. We can pay them creatively so they have the incentive to keep people well. And we need to do that now. And if we can get adequate reimbursement and increased revenue to pharmacists for clinical services, there will be a movement of the young pharmacists that will want to go and expand and create new wellness centers with pharmacies, especially in rural communities all across America. We need them, we can do them, and they will increase our access to care. And then I think, as COVID has demonstrated, telemedicine has worked for employers. They see it as a lower cost opportunity for providers and also for patients. Let's move forward to perfect that new technology. And let's increase the amount of in-home visits by clinicians to our senior populations and to the individuals who have disabilities. That's where we can best reach them, is at home. Let's do it. And then, while electronic medical records have, and other technology like it, have provided an enhanced efficiency and administration in particular, we really have to ask ourselves, can we afford to have our doctors, these expensive clinicians, spending 30% of their time with paperwork? I don't think so. We need that clinical capabilities for providing access to our people. We need less paperwork. And oftentimes that paperwork is excellent for the insurance companies. It's excellent for the administrators at the hospitals and at our facilities. But is it really for the benefit of the people? I don't think so. And finally, I say, we have to ask ourselves, why do patients enter the American healthcare system to begin with? It may surprise you, but the majority of visits to a primary care doctor does not result in a specific diagnosis. And it might also surprise you on the high percentage of those visits are related to a mental health challenge. So I go, let's challenge ourselves to reduce the demand for services by understanding that the number one reason when a person goes to a doctor and they do get a diagnosis, it's related to allergies, sinuses, or upper respiratory conditions. Then it's skin conditions. Then it's headaches. It's lower back pain. It's digestive issues, and hypertension, and for cholesterol. So those are things we can get better at. So let's challenge ourselves, all right, to really become more of our own private investigators for our own health care, to do more self-analysis, to do more self-care, and to explore alternatives, including natural medicine. So in summary, increasing access to healthcare services for our citizens is actually a three-pronged approach. One, we got to create more providers, especially lower cost primary care providers. We need to increase the scope of practice for providers like pharmacists so they can provide more low cost and more greater accessibility to primary care services, including emergencies. And let's challenge ourselves to reduce the demand for services by exploring more self-care and healthy lifestyles. Thank you for joining us today. Our next and final module on this series to explore the healthcare system today will address the high cost of healthcare. Thank you and have a great day.